Hello, I am Dr. Matthew Strehlow.
And I am Dr. Sophia Cohen. Welcome and thank you for joining us. Today, we are going to talk about therapeutics for COVID-19.
During the lecture, we will discuss the key medications beneficial for the treatment of COVID-19.
To understand the treatments, we must recognize the different stages of COVID-19. At the beginning, there is viral replication, so the most effective medications are antivirals. As the illness progresses, the body has a severe inflammatory response, so the most effective medications are immunomodulators and immunosuppressants.
Let's begin discussing immunomodulators, as they are most widely available. Should we use steroids, specifically dexamethasone, for COVID-19 patients?
The recovery trial found that there is a mortality benefit to giving steroids to hospitalized COVID-19 patients who need supplemental oxygen or mechanical ventilation. The dose is 6 milligrams of dexamethasone IV or by mouth, daily for up to 10 days. However, this is a rather low dose and may not be enough for patients with severe disease.
If 6 milligrams is a lower dose, what higher doses are people using?
The Codex trial found that when you increase dexamethasone dosing in mechanically ventilated patients with COVID, acute respiratory distress syndrome, it is safe and decreases the number of days on the ventilator. The dosing was 20 milligrams per day for 5 days, then 10 milligrams per day for 5 days or until ICU discharge.
Understanding both of those trials, then, we should use dexamethasone 6 milligrams per day for patients needing oxygen, and in intubated and ventilated patients with ARDS, give 6 to 20 milligrams per day of dexamethasone and reduce the dose gradually as the patient improves.
What about methylprednisolone?
A small retrospective study suggested that methylprednisolone may be superior to dexamethasone in ventilated patients and equally beneficial in patients requiring oxygen. The dose is 1 milligram per kilogram per day for 3 or more days.
What if dexamethasone is not available?
If dexamethasone is unavailable, use another steroid such as methylprednisolone, betamethasone, prednisone, or hydrocortisone.
Are there any concerns with giving steroids?
There are case reports of steroids leading to Strongyloides hyperinfection syndrome. If a patient is at a high risk of a Strongyloides infection, consider starting empiric ivermectin before starting the steroids.
Can we use inhaled steroids?
A small trial of 139 patients with early COVID-19, both inside and outside the hospital, showed that early administration of inhaled budesonide reduced the need for emergency medical care in COVID-19 patients. The dose was 400 micrograms per puff. Patients took 2 puffs twice a day until symptoms resolved.
Some patients are receiving Tocilizumab. In which patients should we be using this drug?
Tocilizumab is an IL-6 inhibitor. It has shown a mortality benefit when added to dexamethasone in hypoxemic, hospitalized patients with a C-reactive protein greater than 75. Those are the main pharmacologic treatments that modulate the immune systems. What about the medications that target the virus, such as monoclonal antibodies? Are they effective?
Possibly in very specific patient groups. Consider use in outpatients if diagnosis is within 10 days and patient is at high risk of clinical progression. For example, the patient is elderly or immunocompromised. Do not use in hospitalized patients with COVID-19.
What about Remdesivir?
Trials have shown conflicting results with Remdesivir. The World Health Organization does not support its use, while the National Institutes of Health in the United States suggests using it in hospitalized patients who need oxygen. So best to follow local protocols, but it would be used in hospitalized patients.
What about the use of convalescent plasma or hydroxychloroquine?
Randomized controlled trials have shown that neither convalescent plasma nor hydroxychloroquine work for treating COVID-19, and I do not recommend their use. Occasionally, patients may have bacterial infection at the same time as COVID-19. Should we start empiric antibiotics on all COVID patients?
Bacterial co-infection is uncommon in COVID-19 patients on initial arrival to the hospital. Only 4% of patients. We do not routinely start antibiotics in COVID-19. You can obtain blood, sputum, and urine cultures, as well as procalcitonin, to help look for bacterial co-infection.
Should we start antibiotics for very sick patients, especially if they have been hospitalized for a long time?
Good question. Patients who are very sick and have long hospital stays have a 14% chance of getting a secondary bacterial infection. Consider antibiotics on a case-by-case basis in this group. When should you use an inhaled bronchodilator?
Use an inhaled bronchodilator, such as albuterol and ipratropium, if a patient is also having an asthma or COPD exacerbation. For example, if they are having a lot of wheezing. Should I use a meter dose inhaler or a nebulizer to give the bronchodilator?
A meter dose inhaler, or MDI, is preferred over nebulizer because an MDI does not aerosolize the virus.
Avoid nebulizer treatments if possible because they have a higher risk of aerosolization, which increases viral transmission. If you have to use a nebulizer, use it in a negative pressure room if available. If not, a well-ventilated room with a lot of airflow.
8 puffs of inhaled bronchodilators with a spacer are equivalent to 1 nebulizer treatment. Wait 1 minute between puffs.
This is the albuterol inhaler, and this is a spacer. You put the two together in order to get the medication down into your lungs. So what we will do is we'll take off the lid, we'll shake it, and since you haven't used it in a while, we'll clear it, and now it's ready to go. You can shake it up again, and then put it into the spacer, like so. This is a mouthpiece. We'll open that, put your lips around the mouthpiece, take a big breath in, and blow all the air out. When all your air is out, use your 2 fingers to press the inhaler down, and as you do that, take a nice deep breath in and try to hold your breath for 10 seconds. At the end, exhale. For albuterol, wait 1 minute in between puffs.
Another topic we are covering is fluid administration in COVID-19 patients.
The fluids of choice are crystalloids, such as normal saline or lactated ringers.
How much fluids do you give to patients who are in septic shock from COVID-19?
Remember, the number one problem in COVID-19 is hypoxemic respiratory failure, which can become worse when lots of fluids are given. Start by giving a fluid bolus of 500 milliliters to 1 liter over 15 to 30 minutes. Then, check for fluid responsiveness by checking capillary refill, skin temperature, lactate if it is available, also patient's mental status. If your patient is fluid responsive, meaning they seem to be getting better, then give another 500 milliliters to 1 liter bolus over 15 to 30 minutes. However, if your patient is not fluid responsive, meaning you see no improvement after a fluid bolus, then start vasopressors and stop fluids. We have an attached handout for more information about vasopressors.
For post-resuscitation fluid management, target a normal fluid volume for your patient. Avoid continuous fluids to avoid volume overload. If patient has a positive fluid balance, meaning they have a lot more going in than they do coming out, consider diuretics.
In summary, the medications that are best studied and decrease mortality are steroids. Dexamethasone or methylprednisolone should be used for patients on oxygen or who are mechanically ventilated. Tocilizumab decreases mortality in patients on dexamethasone if their CRP is greater than 75. Consider Remdesivir for hospitalized patients, but the evidence is weak. Monoclonal antibodies may be used in high-risk outpatients. Do not use hydroxychloroquine, chloroquine, or convalescent plasma. Avoid nebulizers because they can aerosolize the virus and spread COVID-19.
It is important to recognize that the treatment of COVID-19 is frequently changing as we learn more. Thank you.